for right here. Classically, that's what you see. There's also a couple other parameters that you're looking for. You're looking for radial inclination. So basically, if you draw a line between the distal radius to the DRUJ, you're basically looking at something about 25 degrees. Okay? There's also radial length. So if you end up having a line and you end up having a distance between a parallel line over here at the distal radius styloid from the DRUJ, it should be about 1 centimeter. That's one of the parameters that you're going to be using. That'll also help you with whether or not you need to decide whether to reduce some of these fractures or not. So again, radial inclination, that's what it should look like, 23, 24, 25 degrees. I would just focus on something that's about the average, so about 25 degrees. So again, when you're looking for palmar or volar tilt, it should be about 11 degrees. When you're looking at radial height, again, about 1 centimeter. Okay. Now, a lot of you guys hear about eponyms kind of all the time, but we're going to kind of come back to how to reduce this. But just very quickly, you guys know a Colles fracture. Okay, it's basically a dorsally displaced, dorsally angulated fracture. This is kind of how you should be looking at it. This is what you're going to see on the X-ray. Smith's fracture is the exact opposite of a Colles fracture. It's going to be a volarly displaced, volarly angulated fracture. Usually that's going to be happening when you end up, most people end up fooshing, right? They fall in extended hands. When you end up having a Smith's, it's usually when you fall in a supinated hand. So that's what you're going to be looking for. Bartons are unstables, or unstable fracture. So essentially what you end up having is you have a fracture through either the dorsal or the volar lip of the fracture. You can get an idea how this is unstable. You can get an idea how obviously you don't have congruency of the articular surface right here, and you also have a loss of radial length right here. All of these constitute some of those parameters that we just talked about, which is indicative of maintaining an adequate reduction. Obviously, if you see something like that, it's going to need surgery because it didn't maintain some of those reductions. You don't have the length, you have articular incongruency right there, which I'll go through in just a little bit. These are all unstable. This is what you'll see on basically any kind of, when you see an actual radiograph, this is what you'll see. Here's a volar Barton's right here. This on the other side is a dorsal Barton's. Okay, you can obviously tell the instability that you're having. These you can try to reduce, and you should reduce, but these are definitely going to require surgery. Chauffer's fracture, radial styloid type fractures, okay? Classically, people ended up getting it, obviously, when you end up having a chauffeur. I've never seen a chauffeur in the 21st century. So basically, it's something that you're going to be looked for when you end up having radial styloid pain. Die punch fractures, you'll end up seeing when you end up having a patient who ends up punching a wall. Okay, it's very classic. All of these need to go to the OR. Here's your radial styloid on X-ray. So it depends on if you have, so the question was, does a radial styloid need to go to the OR? It depends on kind of the things that we just talked about, right? So if it appears stable, then you don't need to go to it. It depends on first, whether or not you have a fracture fragment that's actually just kind of hanging off, okay? I would give, if they came into my clinic and I was basically kind of looking at them, I would give everybody a chance to basically be managed operatively. And what you're also going to be finding is that a lot of these patients, on whether or not you're going to maintain that kind of reference to referral for like immediate surgery, is also going to be the patient's pre-existing functional status, right? Is this a 24-year-old athlete who plays field hockey and has to basically kind of like do something, or a 24-year-old athlete who does something else? Or is this a 70-year-old person who fell out of bed? Right, and so you're going to have to kind of maintain that. That's also going to determine how fast you want to get them follow up. Okay, so when we do some of these managements, if you kind of end up starting doing these reductions with me, I think we've done one or two. I think I did one with the mod one time that we tried to put back into place. All of you guys have seen a hematoma blot. Just take 10 cc's. Notice which way we're coming in. We're coming in dorsally. What's volarly? All your nerves, okay? You want to try to kind of avoid these. Basically what you're doing is you're looking for the fracture fragment and you're sticking the needle in. It's a little disconcerting because you're actually going in with either a 22 or, in that picture, an 18 gauge needle, but essentially I want you to go into the fracture fragment. Obviously it needs to be cleaned adequately, it needs to be sterilized. Go into the fracture fragment, try to aspirate blood. If you aspirate blood, you're in the right place, and then you're going to inject about 10 cc's of lidocaine. I usually don't use epinephrine when I do these. Okay? I think most of you have probably kind of heard about the kind of ideas in terms of the concepts in terms of trying to reduce these kind of fractures. But the idea is that sometimes you end up having these, especially with some Colles fractures, when you have these dorsally displaced, dorsally angulated fractures, that the actual distal fracture fragment is locked on the dorsal aspect of the distal wrist. Remember, you need to recreate that fracture fragment, and you're going to be applying axial traction at the entire time, and you're trying to do that to kind of lift over the distal fracture fragment over the distal edge of the remaining bone that you have. Now, I know ortho does all these kind of things. They use the finger traps and everything. That's basically used when you have one person, and it basically helps you maintain the fracture reduction and helps you cast it on your own. You guys have lots of friends over here, right? So I see a lot of different people. In the ER, you're going to have a lot of different help. Okay, if you want to try to reduce one of these on your own, what I would do is just have one person holding on to basically the proximal elbow and the proximal arm, and the other person, you're just shaking your hand. You're going to recreate the fracture fragment by basically extending the wrist backwards while you're applying traction on it. You're pulling on this area, and then you're going to move the fracture fragment over. All right, you're going to have to push it over the distal radius that's in the part that's broke, and then you're trying to align it using those parameters that we just talked about. If you want to use the finger traps, that's fine too. It'll help you maintain it. If you want to, you can put your patients in finger traps and just let them sit. Use about 5 to 10 pounds of traction and just let them sit for a while. And that may help reduce it much in the same way. In a lot of the same way in which when you end up having a shoulder dislocation, some people end up putting them supine, and they simply allow a little bit of traction on the shoulder and allow the muscles to relax and just automatically reduce. Now, the criteria that you should be using for if you want to reduce these is, we said that your normal volar angulation, volar tilt should be about 11 degrees. It should have less than 10 degrees of dorsal angulation. Anything more, you're going to have an unstable, basically you're going to have something that needs to be reduced or something that's going to hit. And if you can't maintain in that, then you're going to need to have your patient sent for surgery. Radial inclination, we said that the normal was about 25 degrees. Less than 15 degrees, you're going to end up needing to probably end up either reducing it or send them to surgery if you can't maintain it. Articular step-offs, right? If you end up having a fracture in the joint and there's more than 1 millimeter of step-off, you should send those patients for surgery. All right, radial shortening, we kind of talked about that with those Barton type fractures. You're going to need to be maintaining that, and I'm going to show you some of the complications of that. And then also, one of the things that I want you guys to end up starting to do and get into the habit of examining when you're looking at distal radius or when you're looking at hands in general is the DRH. Okay, essentially you should be kind of doing what's referred to as piano keying, taking the distal radius, taking the distal ulna, and just flopping it back and forth. If you see a lot of instability in that, that could potentially be a concern that you need to get taken care of later on. It will probably require an arthroscopy from one of your orthopedic surgeons, but it's something you should be getting in the habit of looking at. Just one of the complications, say you send it out, you're in your little kind of place in Kansas, it doesn't get healed well. One of the problems without maintaining that radial length is something called ulnar impaction syndrome. You have this concept of ulnar variance, where the ulna should be, remember, it should be kind of at the same length as that distal radius fragment. If it gets enlarged, what ends up happening is that the ulna ends up impacting on the carpal bones, most notably the lunate, causing a lot of pain, wrist pain, difficult in grip strength. One of the other things, if you don't maintain that volar tilt adequately, like we talked about 11 degrees or so of volar tilt, but the max that you're allowed is about 10 degrees of dorsal tilt, you end up getting some mid-carpal instability. There's something called dizzy, which is a dorsal intercalated segment instability. But essentially, you remember when we talked about the fact that you ended up having these, the carpal bones were nice, they were straight. You had the distal radius, you had the lunate, you had the capitate. When you end up having a little bit of a loss, when you end up having more dorsal tilt than volar tilt, you end up having instability and you end up having basically a shift dorsally of these carpal bones. Again, it causes loss of grip strength, pain whenever you end up having these. These require an osteotomy to be fixed. Immobilization should be in a sugar tongue. All right, where does the sugar tongue go to distally? Looks like I've killed you guys. This is terrible. Dorsally, where does the sugar tongue go to? It goes to the metacarpal, it goes to the MCPs, right? It goes to the metacarpal heads. Volarly, where does it go to? Somewhere right. So it goes to about the mid-palmar crease. Okay, that's where you should be looking at. Remember, you should not be locking your fingers in. You should be having free finger movement, including the thumb. All right, in a sugar tongue. Okay, you guys really should be managing these. things, okay? I understand that there's a lot of different cultures and everything around here. The first part, though, allowing you to manage these things is you have to understand what you're looking for. You have to understand what your consultants really need and what's going to adequately constitute something that your patient's going to be able to tolerate in the future, okay? So just in terms of a summary of everything, remember, look at the fibular fracture. Okay, look at the lateral mal, look at whether it's transverse, oblique, at the level of the joint, or proximal to the joint, to get an idea of whether this is a Weber A, B, or C. All right, every single time you have an ankle fracture, you should have some assessment of the deltoid ligament. Whenever you have a distal radius fracture, you always need to be assessing the median nerve. Okay, you're always going to be assessing for acute carpal tunnel syndrome. And then finally, whenever you end up having one of these fractures, if you start reducing these on your own, just remember the parameters, okay? You can look these up. You don't need to remember these, but remember there are parameters that are going to guide whether or not you've done an adequate reduction and whether or not you can send this out. Okay? Any questions?